Welcome back to the Deep Dive. Today we're plunging into a really important topic in breast health, specifically looking at MRI.
Right.
We're going to break down the characteristics that allow a physician to look at an image and say, with confidence, this is benign.
Exactly. And our mission today really is to give you a kind of shortcut. We're navigating Chapter 7 of the source material.
Okay.
The goal is to pinpoint those key features that let you confidently categorize a finding as benign and, ultimately help avoid an unnecessary intervention like a biopsy.
And avoiding that is, it's such a high-stakes goal
Yeah.
because benign conditions are just so much more common than cancer.
Dramatically more common.
Right. If you look at a symptomatic population, so people with a palpable mass or pain, the prevalence of breast cancer is what, 7 or 8% tops?
That's right. So the vast majority of what we see is benign. And the real power of MRI is confirming that status safely.
But to do that, you need consistency.
You need absolute consistency. And that starts with language. So we have to begin with the foundation, which is the ACR, BI, RADS-S, MRI lexicon.
The standardized language, basically.
It's the international language radiologists use to describe what they see, especially masses. When we talk about benignity, we're really talking about visual predictability.
Okay, so let's get into that. What are the visual cues that just scream low suspicion? The things that offer that instant reassurance?
So when a radiologist gives a mass a BI-RADS-3 category, that means probably benign, the chance of it being cancer is incredibly low.
Like, what are we talking?
We're talking greater than 0, but less than or equal to 2%. And to get that label, a mass needs two key features. First, its shape has to be either round or oval.
Okay, simple enough.
And second, and this is crucial, it must have circumscribed margins.
So, smooth edges,
Uh,
a shape you could, trace pretty easily. If it looks organized, it probably is.
that's a great way to put it.
Which means the opposite must immediately raise a red flag.
Immediately, any descriptor that suggests chaos or, aggressive growth, that's a problem. If a lesion is described as irregular in shape.
Or spiculated, I've heard that term.
Exactly. Or if the margins are irregular or spiculated, so they look like little spikes radiating out, that finding instantly bumps it into a suspicious category, a BI rates 4 or 5.
And that almost always means a biopsy.
It almost always mandates tissue sampling, yes.
So are there any super specific signs, like a visual signature for the most common benign finding, the fibroadenoma?
There is, and it's a beautiful, really specific descriptor. If you have a mass that already has that benign shape and margin.
Round smooth?
Right. And you also see what we call dark internal septations. That is highly, highly characteristic of a fibroadenoma or FA.
Dark internal septations. So that's like non-enhancing lines or stripes cutting through it.
Precisely. They're little fibrous bands that don't take up the contrast agent. It's a classic memorable sign, a real high-value piece of information.
That's a powerful shortcut. Round, smooth, you see those dark lines? You're thinking fibroadenoma. But I know it's not the whole picture.
It's not.
The cancer could look deceptively smooth, couldn't it? Why isn't a perfect shape enough?
Because morphology tells us about the structure, but it doesn't tell us about the behavior.
Ah.
A lesion can look perfectly smooth and oval, but if its internal biology is just building chaotic new blood vessels to feed itself, well, you could mistake a fast-growing cancer for something safe.
And that's where kinetics comes in, the time factor.
Yeah.
So kinetics, that's all about how fast the contrast agent washes in. And just as important, how fast it washes out.
Yeah.
How does that reveal what's happening biologically?
It's really measuring two things, blood flow and capillary permeability. Malignant tumors are aggressive. They build dense, disorganized blood vessels really, really quickly.
Right, real strategy.
It is. So you can think of malignant tissue as being like a leaky, disorganized sponge full of huge holes. The contrast rushes in super fast. But because those new vessels are so porous, it immediately starts leaking right back out into the bloodstream.
And that rapid in and out gives us that classic worrisome curve?
That's the one, the washout curve. We call it type 3 kinetics. You see a really fast initial uptake, more than 100% increase in signal, followed by a significant drop, a washout, in that later phase.
And the benign lesions?
Benign lesions, like our fibroadenoma, they're usually supplied by normal, well-formed capillaries, so that tissue acts more like a tightly woven cloth.
So it absorbs slowly.
It absorbs slowly and holds on. That gives us persistent curves, or type 1 kinetics. Slow initial uptake, usually under 50%, with this steady, persistent enhancement over time.
Okay, that sounds like a nice, clean distinction. But, In medicine, there's always a gray area. Where does this whole system break down?
It breaks down in the middle, the dreaded type 2 or the plateau curve.
The ambiguous one.
This is the critical ambiguous zone. A plateau curve where you have medium uptake, then it just kind of flatlines. You find that in both benign and malignant lesions.
So that plateau, that's the real source of the ambiguity, isn't it? If that's where most unnecessary biopsies come from, that sort of BIREDS4 zone, doesn't it kind of wreck the utility of kinetics?
It's an excellent point.
I mean, if you have a benign-looking lesion but it has a plateau, do you still have to biopsy just because of that kinetic ambiguity?
And that is the immense difficulty of the job. You are often forced to consider it, yes, because the kinetics failed to definitively rule out malignancy.
Wow.
Which is why the #1 rule is that a reassuring kinetic pattern, even a perfect type 1 curve, should never override a worrisome morphology.
So structure trumps behavior.
If the margins look spiculated, it doesn't matter what the curve does. Kinetics is powerful, but when it lands on type 2, you have to defer to the structure.
Okay, so morphology can be tricky, kinetics can be inconclusive, especially with that plateau. Which brings us to a third layer, diffusion-weighted imaging, or DWI.
And its metric, the apparent diffusion coefficient, or ADC.
Yes.
So what is DWI actually measuring? It's a phenomenal tool. It's basically measuring the mobility of water molecules inside the tissue. In short, it tells us how crowded the cellular environment is.
Okay, so crowded cells. How does that affect water?
Think of a subway car at rush hour. The water molecules are the people. In an aggressive cancer, the cells are packed so tightly, what we call high cellularity, that the water is physically restricted. It can't move.
It's stuck shoulder to shoulder.
Exactly. And that restriction is what makes the ADC value go down.
So a low ADC value means restricted water, which points toward malignancy, and benign tissue.
Benign tissue is looser. The cells are more spread out. Water can diffuse freely, so you get higher ADC values.
And there's a specific threshold for this, right?
There is. Researchers have found that ADC values greater than 2.1 times 10 to the -3.
Okay, a very specific number.
A very specific number. If you see that, especially combined with good BIREDS descriptors, you can be pretty confident the lesion is benign.
That sounds almost definitive. But I'm guessing even something common like a fibroadenoma can throw a wrench in this.
Absolutely. And this is the kind of nuance that, keeps radiologists up at night. Fibroadenomas can have really variable ADC values.
Depending on what they're made of.
Precisely. If an FA is my exoid, meaning it's got a lot of water content, it'll have beautiful high ADC values. Great. That helps you avoid a biopsy.
Okay.
But if that same fibroadenoma has really dense stroma or a lot of epithelial hyperplasia, it becomes very cellular.
So it looks crowded.
It looks crowded, it restricts water, and its ADC value can actually drop below that benign threshold. So even though it's benign, its makeup makes it look suspiciously cellular on DWI.
Yeah.
And that can push you back towards the biopsy you were trying so hard to avoid.
We've now officially entered the territory of the mimics, the lesions that just refuse to play by the rules. What are some of the classic benign conditions that look like cancer?
The first major one is adenosis. Pathologically, it's a simple, non-cancerous growth of lobular and stromal tissue, but on an MRI, it can look terrifyingly aggressive.
How so? What does it do on the MRI that makes it such a convincing mimic?
It often shows up with classic suspicious features. You might see a mass with irregular or even spiculated margins.
So the worst kind of margin.
The worst kind. Or you'll just see architectural distortion. And then on top of that, its kinetics can be really concerning. Sometimes it'll show a type 2 plateau or even a type 3 washout.
A walks-out curve on a benign lesion.
So that combination of suspicious shape and aggressive kinetics, it forces a very, very strong consideration of malignancy.
So biopsy is pretty much unavoidable.
It often is, yes, for the safety of the patient. Although DWI is helpful here, a true malignancy will almost always have a lower ADC value than adenosis. But still, the visuals often dictate the biopsy.
What about infections? Like an abscess, do they mimic cancer too?
So infectious things like mastitis or an abscess, they're usually diagnosed clinically, fever, pain, redness.
Right, the patient feels sick.
But on imaging alone, an abscess usually looks like a well-circumscribed, multiloculated lesion, but with this irregular enhancement all around the wall and in the internal septa. And you see inflammation in the tissue around it.
Okay.
DWI is actually really good at spotting an abscess because the thick pus severely restricts water movement, so it gives a very specific signal.
Now, for the biggest curveball, and I think this is probably the highest value insight for our listeners, are there any malignant lesions that do the opposite? that mimic being benign.
Yes, and this is a critical diagnostic
The
pitfall.
one everyone needs to know.
It's called mucinous carcinoma. It's a subtype of cancer that is commonly mistaken for a totally benign fibroadenoma.
How?
It presents as a round or oval mass with perfectly circumscribed margins, and critically, it shows gradual or persistent enhancement.
So, type 1 or 2 kinetics, the safe kinetics.
This safe kinetics, it looks soft, it looks round, it acts slow, but it's cancer.
Why does it trick the MRI? What's the biology behind that?
It's all in the name. Mucinous. The tumor produces huge amounts of sticky, gelatinous mucin.
Like a jelly.
Exactly, and the contrast agent needs to diffuse through the tissue, but this mucin is like thick honey. It physically slows down the contrast. It gets bogged down. So that classic washout signature of malignancy it never appears. It's a biological ambush.
Let's shift gears to follow-up care. So after a patient has had surgery, a lumpectomy or something similar, the scar tissue can create a whole new set of benign findings that can really complicate future MRIs.
Right, and the most common one is fat necrosis.
Which is?
It's just inflammation that happens after an injury to fat cells. But the healing process happens in stages. And in phase 2, the scar formation phase, the body creates granulation tissue.
And granulation tissue needs new blood vessels.
It requires angiogenesis, new blood vessel formation.
Which means new blood flow. Which means contrast enhancement.
And that temporary enhancement can look exactly like a tumor recurrence.
That's a huge problem.
It is. The enhancement is often peripheral, so it's around a fatty center, and it can look highly suspicious. This brings us to probably one of the most critical pieces of clinical timing in post-op care. Okay. If you're doing an MRI after surgery to check for any residual disease, it absolutely should be done during the first week after surgery.
Wait, only 1 week? So if surgery's on a Tuesday, the MRI has to be done by the next Tuesday. Why is waiting even, say, 10 days a potential disaster?
Because it's a functional catastrophe. By day 10, the body's biological clock has already switched from the injury phase to the active healing phase.
The scar is forming.
The scar is forming, that granulation tissue is proliferating, and all those new blood vessels start to light up with intense enhancement that can look identical to a recurrent tumor.
So you get a devastating false positive.
You get a false positive, which leads to immense patient anxiety and probably another unnecessary biopsy. Sticking to that narrow 1-week window is the best way to avoid it.
And what about long term? Years down the line, how do you know a chronic scar isn't cancer? Because scars can look distorted forever.
They can. But chronic scarring stabilizes. It should reach a stable size or even decrease after about 2 years. The most reassuring sign long-term is the absence of uptake after contrast.
No enhancement at all.
A stable, spiculated scar that shows zero enhancement it's virtually always benign. That's how you can differentiate it from a recurrence with very high accuracy.
So this whole deep dive has really shown that while there are core rules for benignity round, smooth, persistent kinetics, high ADC,
Right.
the exceptions are. They're frequent and they're dangerous. You have benign things like adenosis that look aggressive, and then malignant things like mucinous carcinoma that look totally benign.
Absolutely. The clinical reality is we are constantly wrestling with these subjective visual calls. Is that spiculated or just irregular? Is that plateau curve just high enough to be a worry? It's a multi-factor decision based on imperfect data.
Which, that raises a really important question for the future, doesn't it? We know from the source material that there are quantitative techniques like pharmacokinetic analysis.
Good gaze analysis, yeah.
Using these advanced parameters like K-trans, the volume transfer rate, to objectively measure how a known cancer is responding to treatment.
That's right. Those metrics can objectively measure exactly how leaky those capillaries are. It's actually a much better predictor of therapy response than just measuring if the tumor shrank.
So here's the final thought then. If we can quantify aggressiveness in a known cancer, why are we still using subjective visual curves to rule out harmless findings?
It's a very powerful question.
Could we see a future where the standardization of these advanced quantitative methods, like K-trans or some other biomarker, could finally give us the accuracy to definitively classify even the most ambiguous benign lesions.
You mean like those tricky plateau curves or the cellular fibroadenomas?
And truly, finally, eliminate every single unnecessary anxiety-inducing biopsy in the world.
Moving from qualitative observation to quantitative functional markers, that's the next essential step. It offers the potential for complete diagnostic certainty. That objective metric, that is the frontier we need to cross.
A fascinating possibility. Thank you for guiding us through this. This was incredible.
My pleasure.
We'll see you next time on The Deep Dive.